We have an 80-year-old lady brought to the emergency department due to progressive lethargy. Patient has a history of Alzheimer's disease and baseline is convergent and able to indicate her needs. But for the last several days, she had been somnolent and lying in the bed most of the time. 2 weeks ago, the patient was treated with ciprofloxacin for urinary tract infection. Now BP is 88/60, pulse 126. Mucous membrane are dry, that definitely indicate dehydration. Important clue that we got it, and we should not forget her BP is 80/60. It may be contributing. Let us see. Well, lab study shows that BUN is very much increased. Creatinine is increased. Glucose in the normal range, and her serum creatinine was 0.9 a month ago. But now both are increased. But point to be noted, if you note 61 and 2.1, that means BUN is much more increased. If you see the ratio of these 61 to 2.1, it comes out to be almost 43:1, almost something like that. At least more than 40:1, you can say. Definitely, BUN increase is much more than creatinine. And as far as urine is concerned, it is almost normal. There is no cast, no protein. Most likely cause of this patient current renal problem is, the answer is intravascular volume depletion. Well, this we also got a clue when we saw the mucous membrane was dry, that I told you that it indicate dehydration. Now patient has tachycardia, hypotension and dry mucous membrane. Mucous membrane are dry, BP 88/60, pulse tachycardia. They all indicate depletion of intravascular volume. And this can lead to a type of pre-renal kidney injury, so-called pre-renal failure. Pre-renal failure or pre-renal acute kidney injury also. Elderly patients are especially susceptible to volume depletion due to impaired thirst response, and moreover, inability to obtain food and water without assistance due to dementia. Our patient is already a case of Alzheimer's disease. It is more likely that the patient was not able to drink water, and that lead to volume depletion. Hypovolemia lead to decreased renal blood flow, and this causes activation of renin-angiotensin aldosterone system, what we call as RAAS. And this causes increased sodium reabsorption of salt and water, and this lead to increase in passive reabsorption of urea also. So first of all, let me talk to you regarding RAAR. This is the nephron. And we all know very well that aldosterone, A for aldosterone, it causes sodium absorption. Water follows passively, sodium is absorbed actively. But two positive particles have come in. As per response, to maintain electrolyte balance, body has to lose two positive particles, one HI and one potassium goes out. But when massive dehydration occurs, body wants more and more salt and water. Body will secrete more and more aldosterone. More aldosterone will lead to what? It will cause more and more sodium and water to come in. Water follows passively. Of course, that will lead to massive loss of potassium and HI also. So that will lead to hypokalemia and metabolic alkalosis. HI is being secreted. But at the same time, okay, so now we understood how this RAAS is going to cause increased sodium and water reabsorption. Now the point, and one more thing, in pre-renal failure, ratio of BUN creatinine is more than 20:1. In this case, the ratio is 43:1, which I said earlier also, somewhere around 42, 41 to 3. Definitely it is more than 20:1. That is a classical feature of pre-renal failure. Okay. But now the question is, why urea is absorbed more as compared to creatinine? Stop the video, write down the answer. Well, the answer is, this is the nephron. And we have ADH, antidiuretic hormone. It causes absorption of pure water, only pure water. It has got no role in sodium and chloride absorption. But in addition to water, it also absorbs urea. Okay, so now in this condition, in dehydration, ADH level is increased because they want to conserve more and more water. Urea is also absorbed passively, and that's the reason why urea become much more than as compared to creatinine. The carry-over message is ADH not only absorbs water, it also absorbs urea also, and this point is not known to most of the students. Okay, so now if the decreased renal perfusion is prolonged because of dehydration, it can lead to acute tubular necrosis. So in the advanced stages, it can again become acute tubular necrosis. In the initial stage of pre-renal failure, urine analysis is unremarkable, no cast, no RBCs, but in the absence, so protein, cell, and cast are typically absent. This is a feature of pre-renal failure. Now let's look into other option. As far as this concern, age-related renal function decline, this occurs due to renal mass and thickening of glomeruli basement membrane. But process is gradual and cannot account for this patient laterally abrupt decrease for the past several days. Okay, it was not a matter of few days. This cannot occur in few days. It's a matter of years together. So this option ruled out. Atherosclerotic renal vascular disease. This is typically lead to renal artery stenosis. Renal artery stenosis. Okay. Significant bilateral is required to result in serum creatinine elevation, and moreover they present with hypertension, no hypotension. In our case, hypotension is there. Well, we also know that RAS can occur in young ladies also. What is the pathological reason in young lady? In elderly, it is atherosclerosis. My question is, what happened in the young lady? Stop the video, write down the answer. Answer is fibromuscular dysplasia. Well, let's talk about drug hypersensitive reaction option C. This lead to acute interstitial nephritis. Patient was given ciprofloxacin for UTI. It can lead to AIN, but there is no leukocyte cast, no skin rash, and that make AIN as not a choice. Increased CVP, this occurs in volume overload state due to heart failure. This can lead to prerenal AKI because of impaired forward flow, because when congestive heart failure occur, that lead to reduced renal blood flow. RBF stands for renal blood flow. And however, dry mucous membrane will not be a feature. In our patients, the mucous membrane are dry, so this option ruled out. A quick recap of the pre-renal acute injury. Last revision point, etiology, any reason due to decrease renal perfusion. It could be total volume depletion, like in our case, decrease effective arterial blood volume, like in heart failure. Dysplasm of intravascular fluid, sepsis, pancreatitis, renal artery stenosis, efferent arterial vasoconstriction typically occurs by NSAID. The clinical feature, increase in creatinine, decreased urine output, BU and creatinine ratio is one of the most important criteria. Fractional excretion sodium less than this is important criteria, but this is the most conformity criteria. And urine saliventer are planned. And treat the basic cause is the treatment of acute renal failure. Golden line to remember, difference between pre-renal and intrinsic cause of renal failure. BU and creatinine ratio 20:1, 10 or 15:1. Urine sodium less than 20, more than 40 milliequivalent per liter. Urine osmolality more than 500, less than 350. Fractional excretion of sodium, what we call as FENA. What we call as FENA. Less than 1%, more than 2%. Urine plasma creatinine ratio more than 40, less than 20. Renal failure index less than 1, more than 1. Thank you very much.